So, good morning all. On behalf of Department of Endocrine Surgery, I welcome you all to this CGR session. And our last two CGRs have been on surgical techniques, namely endoscopic and robotic thyroidectomy. So this time we decided to share some interesting and fascinating cases of genetic syndrome as we encounter in our department. And the team has decided that they will be providing you a brief overview followed by case presentation and some snippets related to major genetic syndromes which we encountered in our department. And this team would consist of Dr. Spandana, Dr. Ranan, and Dr. Divya, who are our second year MCH students, or rather they say fourth second year because they have yet to complete 1 year with us. And let me start the ball rolling. So, as we all know that genetic endocrine syndromes are very rare disorders. And however, we do encounter in considerable proportion of certain disorders which we manage in our practice. Needless to state that identification and classification of various genetic association syndromes and susceptibility genes are increasingly relevant to endocrine surgery patient care, and the team would be showcasing exactly that in the presentation. So just to give you a perspective that in our department, the major organs which we deal with are thyroid and parathyroid. However, there is slight paradox in the form that these disorders are not very commonly associated with hereditary syndromes. However, the adrenal and endocrine pancreas, which are rare, but in these disorders, there are considerable proportion of genetic syndrome, which we encounter. And it is also quite interesting to note that within same organ, the tumors arising from different cell origin, the incidence of genetic syndromes vary quite greatly. And most of the genetic syndrome which we manage have known genotypic and phenotypic association. Some are very well established, like multiple endocrine neoplasia syndrome. However, with advances in medical sciences, we are increasingly discovering new syndromes. So this is a brief overview of the various organs and associated syndrome. As I said that in our department, thyroid and parathyroid remains the common organs which we manage. In thyroid, this thyroid cancer arising from follicular cells comprises majority or more than 90% of thyroid cancer, but the incidence of genetic syndrome is very minuscule in these cases. Whereas medullary thyroid cancer, which comprise only 5 to 7% of thyroid cancers, the incidence of genetic syndrome is quite high. Means 1/5 to 1/4 of such cases would be having some kind of genetic syndrome. Now coming to parathyroid. Parathyroids are in fact world over the most common endocrine surgery disorder which is being managed by an endocrine surgeon. These are associated with some very fascinating and varied genetic syndromes. However, overall incidence of these syndromes is very high. Whereas, as I just said, that adrenal and pancreatic tumors, they are very rare, but incidence of genetic syndromes is considerable within these organ system. And here also an interesting point to note is that within adrenal also, the tumors arising from adrenal cortex are very common. In fact, 1 out of 10 among us sitting in this hall would be harboring an adrenal incidentoma in form of adrenal adenoma, but they are rarely associated with genetic syndrome. Whereas the tumor arising from medulla and septentroadrenal system, they are very rare, but commonly associated with genetic syndrome in form of VHL and multiple endocrine neoplasia. However, it is also very important to state that not only cell type, but age of the patient also, as is expected, would also influence the incidence of genetic syndrome. Like in childhood adenocortical tumors, the incidence is very high. Endocrine pancreas are very rare tumors with the incidence of 1 to 2 per million population. But when we do encounter these syndrome, we always have to look for genetic association. So as a surgeon, what is the implication of identification of these syndromes for us is that if we can identify genetic mutation, then there is a possibility of precision surgery and overall better optimal management and outcome. I'll just give you an example. Like if we know that a patient is of pheochromocytoma belongs to a familial group, there we could offer a cortical preserving adelectomy rather than total adelectomy. And therefore, we could spare that child or in long-term an individual the devastating consequences of Addison's disease which occur after bilateral adelectomy. It is very important to note, and we can understand that whenever we encounter these genetic syndrome, tumor multicentricity is a known phenomenon. Then this thing, if we know that a patient is harboring a particular mutation, then the tumor surveillance and surveillance of other component becomes quite easy. In past, what we were resorting to is that if we identify a multiple endocrine neoplasia patient, the offsprings or first degree relative would be subjected to annual biochemical screening. Many of these are autosomal dominant disorder. So with identification, the follow-up of and screening of affected individuals also become very easy. And one of the very successful story of bench to bedside application is familial NTC. With the identification of RET oncogene, it is possible to offer prophylactic total thyroidectomy to the offspring of a patient. And in these cases, prenatal diagnosis and counseling is also possible. So with that, I would like to invite my younger colleague, Dr. Spandana, who would be sharing with you a case of familial thyroid cancer. Dr. Spandana.
Thank you, ma'am. I shall now be elaborating on familial thyroid cancers and our departmental experience in managing them in brief. Thyroid cancers are the most common endocrine cancers. Based on their cell of origin, the most common type is a differentiated thyroid cancer, which arises from the follicular cells. Medullary thyroid cancer, which accounts for only 3 to 5% of the cases, arises from the parafollicular cells. Medullary thyroid cancer is most commonly sporadic in nature, with hereditary cases accounting for 20 to 25%. These hereditary cases are associated with multiple endocrine neoplasia type 2A and 2B. MEN2A syndromes are associated with medullary thyroid cancer, pheochromocytoma, and primary hyperparathyroidism. MEN2B syndromes are associated with medullary thyroid cancer, pheochromocytoma, mucosal neuromas, and marfanoid habitus. They are due to an autosomal dominant red gene mutation on chromosome 10. Familial medullary thyroid cancer, which was previously considered as a separate entity, is now being considered as a variant of MEN2A syndrome. Further elaborating a case of familial medullary thyroid cancer, we had a 39-year-old gentleman who had a history of excision biopsy of his right cervical lymph node done elsewhere in 2019. His histopathology was reported as a metastatic medullary thyroid cancer. However, he was lost to follow-up, and when he presented to us, he came with the complaints of fever and associated with chills and rigors and weight loss for 30 days. He had a PET CT scan done outside, which showed tracer-avid lesions in both his adrenals and both lobes of thyroid. However, there was no evidence of any distant metastasis. On examination, he was average built and was normotensive. He had a scar mark of excision biopsy on the right side of his neck. A 1 into 1 centimeter nodule was palpable in the right lobe of his thyroid. 2 1 into 1 centimeter lymph nodes were also palpable in the right level 3 lymph node group. To further characterize his lesions, we went ahead with an ultrasound of the thyroid, which revealed hypoechoic solid lesions confined to both lobes of the thyroid gland and multiple subcentimetric cervical lymph nodes. Ultrasound-guided fine needle aspiration cytology of both these lesions were consistent with medullary thyroid cancer. We measured his serum calcitonin level, which is both a diagnostic and a prognostic tumor marker for medullary thyroid cancer, and it was found to be grossly elevated. Keeping in mind his PET-CT findings, which are suggestive of bilateral pheochromocytoma, we had a strong suspicion of a familial syndrome. On estimating his 24-hour urinary metanephrine and normetanephrine level, they were also found to be grossly elevated. However, his serum parathormone level and serum calcium levels were within normal limits. To further stage his disease, we went ahead with a contrast-enhanced CT scan of his neck, thorax, and abdomen, which revealed lesions confined to both lobes of the thyroid with no evidence of any distant metastasis. He tested positive for REC mutation on codon 634 on chromosome 10. It is important to know that all patients with a presumed sporadic MTC should have genetic testing done to detect a germline REC mutation as recommended by all international consensus, including the American Thyroid Association. With this, we made a clinical diagnosis of a MEN2A proband with medullary thyroid cancer, stage T1M, N1B, M0 with bilateral pheochromocytoma. Further plan of action was to surgically manage his pheochromocytoma, followed by medullary thyroid cancer, and to do a genetic screening of his family members. Management of pheochromocytoma takes precedence over that of medullary thyroid cancer to avoid any untoward hemodynamic catastrophe intraoperatively in the presence of an untreated pheochromocytoma. This can be done either by a stage procedure or in a single sitting. In our patient, we did a stage procedure given his large volume of adrenal tumors. We performed an open transperitoneal bilateral adrenalectomy, and the histopathology was consistent with pheochromocytoma. We then proceeded with total thyroidectomy with central compartment lymph node dissection with bilateral selective lymph node dissection. Intraoperatively, all his parathyroids were visualized and were found to be normal. On grossing, the tumor was multicentric, which is consistent with a familial disease. He had an uneventful postoperative period, and his final histopathology was reported as medullary thyroid cancer. Further plan of action was to keep him on regular follow-up to rule out the recurrence of medullary thyroid cancer by doing serial physical examination and imaging investigations, and to test his tumor markers like serum calcitonin and serum CEA levels. We'll also be keeping the patient on annual follow-up to rule out the recurrence of pheochromocytoma by estimating his 24-hour urinary metanephrine and normetanephrine levels. The patient will also be put on annual surveillance to pick up primary hyperparathyroidism by estimating his serum calcium and serum parathormone levels. On genetic screening of his family members, both his children tested positive for REC gene mutation of codon 634 on chromosome 10. The younger child who tested positive had unremarkable examination, imaging finding, and a normal calcitonin level. We performed a total thyroidectomy, and on histopathology, there was no evidence of any malignancy. The older child who tested positive for this mutation had an unremarkable examination and imaging findings, but had an elevated calcitonin level. We performed a total thyroidectomy in her, and the histopathology revealed medullary thyroid cancer in the right lobe of the thyroid. This illustrates the importance of offering early surgery in carriers of these mutated genes, as medullary thyroid cancer is the killer disease in these syndromes. Giving an overview of the American Thyroid Association guidelines on medullary thyroid cancer, all patients need to undergo genetic analysis for REC gene mutation. If found positive, they should be evaluated for pheochromocytoma, primary hyperparathyroidism, treated accordingly, and based on their serum calcitonin level, further management of medullary thyroid cancer should be undertaken. Based on the codon mutated, all these patients are risk categorized into moderate, high, and highest risk as there exists a certain genotype to phenotype correlation. Patients who test positive for 634 codon are categorized as high risk based on ATA guidelines, and they should be offered prophylactic total thyroidectomy before the age of 5 years. Patients of MEN2B syndrome who have a mutation of 918 codon, categorized as highest risk, should be offered surgery within infancy. It is also important that genetic counseling for options of pre-implantation or prenatal diagnostic testing should be considered for all RET mutation carriers of childbearing age. Further emphasizing the role of prophylactic total thyroidectomy, These patients with a syndromic association have an autosomal dominant. Medullary thyroid cancer has 98% penetrance, and doing a prophylactic total thyroidectomy is 100% protective for medullary thyroid cancer. Next, coming to a case of a MEN2B syndrome managed in our department. She presented with all the characteristics of the syndrome, such as medullary thyroid cancer, bilateral pheochromocytoma, mucosal neuromas of the lip and the tongue, and a characteristic marphonoid habitus. Since its inception, over the last 33 years, our department has managed 1,750 cases of thyroid cancer, out of which 220 cases were medullary carcinoma of the thyroid. 18% of these patients were hereditary, out of which majority belong to MEN2A syndrome, which is consistent with the world literature. Projected here are some of the departmental research works on familial medullary thyroid cancer. I now call upon my colleague, Dr. Divya, to share an illustrative case of familial primary hyperparathyroidism and share our departmental experience of the same.
Thank you, Dr. Spandana. Elaborating further on familial endocrine disorders, I will be discussing familial primary hyperparathyroidism. Primary hyperparathyroidism, commonly referred as PSPT, is a common endocrine surgery disorder we come across in clinical practice. The prevalence of the disease is 1 in 400 to 1 in 1,000 population, out of which familial PSPT is only of 3 to 5%. There are various syndromic and non-syndromic familial disorders which are associated with familial PSPT, as depicted in this picture. Multiple endocrine neoplasia type 1 or MEN1 being the commonest one, accounting for 75% of all familial PSPT. To give you an overview about MEN1, it is an autosomal dominant disorder, commonly known as syndrome of 3 Ps, as it involves parathyroid, pituitary, and pancreas in form of PHPT, pituitary adenoma, and pancreatic neuroendocrine tumors. There can also be various non-endocrine tumors as depicted in this image. Discussing here a case of familial PHPT, which we have managed in our department. She's a 32-year-old lady, presented with chief complaints of intermittent galactorrhea for the past 10 years, irregular menses and headache for the past 5 years. She was initially presented to endocrinology OPD in 2012 with above complaints and diagnosed to have prolactinoma. As her serum prolactin was raised, an MRI brain was suggestive of a suprasellar mass. She was then managed conservatively with dopamine agonist. Followed by that, she was defaulted for 5 years and again presented in May 2022 with complaint of bilateral flank pain. She was then evaluated and ultrasound KUB was done, which was suggestive of bilateral renal calculi. In the background of presence of prolactinoma and calculus in young patient, she was suspicious of having familial PHPT. On evaluation, her calcium and parathormone was found to be raised. So in this patient, a diagnosis of MEN1 was made based on her clinical picture, as she had 2 MEN1 associated disorders in form of pituitary adenoma and PHPT. Further probing into the family history, we found that her elder brother had history of recurrent renal stone and neck surgery, and also her father had history of renal stone. On examination, she was of average build and had no significant findings on neck and systemic examination. On biochemical evaluation, her calcium and parathormone levels were found to be high, with low level of serum phosphorus, which was consistent with diagnosis of PHPT. Her prolactin levels continued to be elevated. Though localization studies in form of ultrasound neck and MEB scan is not necessary in case of MEN1, as all glands are expected to be involved, ultrasound of the neck was done as a part of departmental protocol, which was suggestive of an enlarged parathyroid gland at the lower pole of the right lobe of thyroid. MEB scan was also done in this patient to look for any ectopic parathyroid gland as is expected in familial cases, and it revealed increased stressor uptake in right upper paratracheal region just above the arch of aorta. As a part of assessment of end organ damage, DEXA scan was done, which revealed osteoporosis maximum at cortical bones like distal end of the radius. A follow-up MRI brain for prolactinoma showed a lesion in the posterior sella on right side. As all parathyroid glands, both normal and ectopics, are likely to be involved in all familial cases, as per recommendations, conventional four-gland exploration or bilateral neck exploration was done. This was followed by subtotal parathyroidectomy, which is excision of 3 or more glands, and thymectomy was done in this patient in order to take care of any ectopic parathyroid glands, as it is the most common side of ectopic parathyroid. Intraoperatively, 3 out of 4 normally located glands were enlarged and excised. Also, an enlarged ectopic parathyroid gland was visualized in the right limb of the thymus. She had an uneventful postoperative period. Her histopathology was reported as multiglandular parathyroid disease with an unremarkable thymus. Our further plan for this patient is to periodic serum calcium estimation to detect any recurrence, serum chromogranin estimation to detect pancreatic neuroendocrine tumor, and genetic testing if feasible. For prolactinoma, she continues to be managed by conservatively by our colleagues in endocrinology department as it was small in size. Here illustrating another familial PSPT which we have managed in our department. She had, in addition to PSPT and pituitary adenoma, also had pancreatic neuroendocrine tumor, which are managed conservatively. Here to emphasize, like familial PSPT, familial pancreatic neuroendocrine tumors are also multicentric, and there are no clear-cut guidelines on surgical management of these tumors. She was further subjected to genetic testing and found to be positive for MEN1 mutation. Here giving a comparative analysis between familial PSPT and familial medullary thyroid carcinoma. PSPT is far more common than medullary thyroid carcinoma. The incidence of familial PSPT is very less, seen in the projection. The killer disease in familial PSPT associated, killer disease in familial syndrome associated with MTC is MTC itself, whereas it is pancreatic neuroendocrine tumors in case of familial PSPT. Hence, prophylactic surgery is questionable or not possible in case of familial PSPT, as prophylactic pancreatectomy is not viable. While in MTC, as already discussed by Dr. Spandana, prophylactic surgery is recommended. Coming to genetic analysis, genetic testing is the standard of care in medullary thyroid carcinoma. However, in familial PSPT, it is recommended or can be done depending on the feasibility. The reason for this being the unavailability of the testing, the larger side of the gene, and there is no clear-cut genotypic and phenotypic relationship in familial PSPT. Now, to just give a brief overview of our departmental experience in managing these cases, we have totally managed 592 cases of PSPT, out of which 3.3% are familial, and a majority of them are of MEN1. Because the facility of genetic testing is not available in our institute currently, and only a few commercial labs of the country are testing for it, we have not been able to test in all our suspected cases of familial PSPT, unlike familial medullary thyroid carcinoma. Hence, we rely on taking a good familial history in case of PSPT to diagnose familial PSPT. Though we have many landmark publications in relation to PSPT in developing countries, these are few publications related to familial disease. Now, my colleague Dr. Rinal will be illustrating a familial pheochromocytoma and our departmental experience.
Thank you, Dr. Dibya. In continuation with the familial endocrine syndromes, I will be presenting the familial pheochromocytomas. As an overview, pheochromocytomas are of adrenal origin and extra-adrenal origin, and these extra-adrenal pheochromocytomas are now called as paragangliomas. Pheochromocytomas account for less than 0.2 to 0.6% of secondary hypertension. Historically, these tumors were known as 10% tumors. However, recent studies show that around 1/3 to 2/3 are associated with hereditary syndromes. Pediatric and extra-adrenal pheochromocytomas are more likely to be familial. Depending on the age and location, the incidence of familial pheochromocytoma may vary. The different syndromes and genetic mutations associated with pheochromocytomas are von Hippel-Lindau syndrome, multiple endocrine neoplasias type 2A and 2B, neurofibromatosis type 1, and SDH mutations. My colleague Dr. Spandana has already given an overview of the familial MEN syndromes.
So I will be presenting a case of familial von Hippel-Lindau syndrome associated pheochromocytoma managed in our department. This is a case of a 24 years lady who presented with headache, nausea, vomiting, dizziness, loose stools, and altered sensorium for 2 days. She was found to have accelerated hypertension and was started on 4 antihypertensive medications outside. At presentation to us, she was disoriented, she had raised blood pressure levels, and an irregular breathing. She was initially managed by the neurosurgery department. An urgent MRI was done, which showed a space-occupying lesion in the cerebellar region. Due to deteriorating sensorium, she underwent an emergency suboccipital craniotomy and excision of the space-occupying lesion. Post-operatively, her GCS improved. However, she continued to have raised blood pressure levels. Her histopathology reported a left cerebellar hemangioblastoma. In this clinical setting of a hemangioblastoma and raised blood pressure levels, this arouses suspicion of possibly VHL and pheochromocytoma being the cause of secondary hypertension. So she was then referred to our department for further evaluation. On further evaluation, she was found to have elevated fractionated 24-hour urinary normetanephrine levels. Her CT abdomen showed bilateral adrenal masses of 5.2 centimeters on the right side and 4.9 centimeters on the left side, along with a pancreatic space-occupying lesion of 2.1 centimeters in the uncinate process. There were no lesions in the kidney or the adnexa. This confirmed our clinical diagnosis of VHL, and we went ahead with investigations for further components of VHL. And she was found to have bilateral moderate conductive hearing loss and bilateral grade 4 retinopathy and papilledema. Hence, we made a final diagnosis of VHL syndrome with secondary hypertension due to bilateral pheochromocytoma with pancreatic neuroendocrine tumor and cerebellar hemangioblastoma. On further pedigree charting, her relatives gave a history that her elder brother had bilateral pheochromocytoma and was operated 18 years back, which they had not revealed to us due to social reasons. On genetic testing, she was found to have a mutation in the VHL gene. In view of large size of tumor and other components of VHL, like pancreatic neuroendocrine tumor, the patient was planned for bilateral transperitoneal open total adrenalectomy with Whipple's procedure. At surgery, she was found to have blood pressure fluctuations in the form of blood pressure surges during tumor manipulation and hypotension after tumor removal. She had a 2 into 2 centimeter hard mass in the uncinate region. Her histopathology revealed bilateral adrenal pheochromocytoma with well-differentiated pancreatic neuroendocrine neoplasm. She was subsequently discharged on replacement doses of corticosteroids and mineralocorticoids. She's on regular surveillance with us, and we are now planning screening of her other first-degree relatives. VHL syndrome is characterized by the presence of benign and malignant tumors affecting the CNS, kidneys, adrenals, pancreas, and reproductive organs. CNS hemangioblastomas are the most common presentation in VHL syndromes. However, the presence of VHL in hemangioblastoma is rare. Pheochromocytomas in VHL present in only 10 to 20% of the cases. The VHL screening guidelines highlight the importance of screening in VHL as early as 8 years of age. Had her family been more vigilant, this patient could have undergone a cortical sparing adrenalectomy, and she could have been spared of a lifetime use of steroids. Based on the genotype and phenotype correlation, there are 2 types of VHL, and we most commonly deal with type 2. As per current guidelines, all patients less than 45 years of age should undergo genetic testing. Based on the presentation, this patient could have guided us in genetic testing based on the location, biochemical phenotype, if malignant, and if a family history is present, we could have performed a targeted genetic analysis. These are a few case snippets of the other familial syndromes associated with pheochromocytoma that we have managed in our department. This is a case of a 36-year lady who presented with sweating, palpitations, and hypertension with multiple cafe au lait spots and neurofibromas and Lisch nodules. She was found to have neurofibromatosis type 1 and a right adrenal pheochromocytoma. This is another case of a young lady of 25 years of age who presented with accelerated hypertension. She had multiple extra-adrenal pheochromocytomas and bilateral glomus tumors. On genetic testing, she was found to have SDHD mutation. Our department is a leader in endocrine surgery in India. And since its inception, we have managed around 336 adrenal and extra-adrenal pheochromocytomas, out of which 24% have been familial. According to world data, VHL is the most common syndromic association. However, in our data institutionally, we have found that MEN2A syndromes is the most common. And this could be an underestimation since VHL testing has recently started and most patients have logistic or financial issues. Projected here are some of our departmental publications on familial pheochromocytomas. I now call upon Professor Anjali Mishra ma'am to give her concluding remarks.
So actually, just to complete the quorum, one of our students could not make it due to certain unavoidable reason. And as such, as I told you, familial pancreatic neuroendocrine tumors are quite rare. And we should be dealing with more gastrinoma, but somehow we are missing those due to probably advent of pantoprazole and other H2 blockers. And our experience is restricted to insuloma. And the numbers would appear quite modest, but it is very important to understand that even at Mayo Clinic, which is a leader in managing insuloma, they manage only 15 to 20 cases per year. And out of these cases managed, we encounter 13% of MEN1 syndrome patients. So just to conclude that over the years, what we have witnessed is that pickup rate of genetic syndromes have improved. And we are really grateful to our sister department, medical endocrinology, particularly Dr. Bhatia, who has started MEN2 testing in the department and which has been later taken care of by genetic department. And we are very fortunate that they have started offering VHL testing to these patients. And as was aptly clear from the presentation, the primary management and follow-up of these cases are quite simplified once we know a known mutation. And here also it is important to emphasize that these cases would require multidisciplinary and experienced team at Center of Excellence, because majority of these cases would be needing lifelong follow-up. And however, this thing, I would say that genetic testing availability, affordability, and acceptability is still an issue with us. And majority of the genetic mutation detected in our experience have been part of some MCH projects where this thing funding was available from intramural funding system. And however, we look forward to continued support and association from other sister department, and we will strive to achieve better. So here I would like to acknowledge all my collaborators. Thank you very much. And I would, and our team would be open to any questions and comments.